Hello, welcome. I'm Dr. John Cruz. I hope you've had a manageable week. And today I'm going to be talking about depression and ADHD. The format's the same as the last several weeks. I'll be talking for about 15 to 20 minutes. And if you have questions while I'm talking, you're welcome to write them down. If you have questions later, you can also, this will be posted on the Facebook page and you can write in questions I can try to answer then. If there are questions, I have up to another 15 or 20 minutes for answering questions if those come in during the time we're here. Next week's talk will be about alcohol and why it's not your friend. And what I'll say to start out with is that this is going to be necessarily a highly idiosyncratic talk because the topic of depression could fill hours and hours. So I'm going to try to focus it on some interactions with ADHD and some highlights of what I think are important. Starting with stressing how big an issue this is. So the World Health Organization, when they're not busy battling the COVID epidemic, have said, and this has been true for several years now, that depression is the disease that causes the most financial distress, dysfunction, loss of income, on this planet. And the reason for that is one, depression is highly prevalent. Two, it causes a lot of dysfunction, lost work, lost lives when it's present. And three, it particularly affects people starting at much younger ages. So, a third of us in the US wind up dying of cancer, and yes, there are pediatric cancers, but by and large, that's a disease of old people towards the end of their productive work lives, and not that that's the best measure of productivity. Similarly with heart disease, that's primarily a disease of aging, whereas depression starts pretty early on, causing distress. So some studies have suggested that up to a third of people who are diagnosed with depression do have ADHD. So, and conversely, people who have ADHD probably have rates of depression that are 2 to 3 times higher than depression in the general population. So there's probably aspects of ADHD that predispose to depression. Depression itself shouldn't be causing ADHD in ways we know, but again, the two are commingling and working together. Three big facts seem to jump out from every single epidemiologic study looking at depression in terms of what causes depression and why it's there. So although we cannot find these factors in absolutely every individual, the three factors that jump out in every single study that's looking at it suggest that most people with depression have some substantial trauma in their first decade of life, and trauma can be parents separating, important figures dying, important major injuries, and separation of parents, even if it's completely amicable, is a trauma at a psychological level. So early trauma, big trauma is one thing that jumps out in all these studies. Genetics is the second one. So most people with depression have depression in other family members. There's a strong genetic contribution. It's actually not as strong as the contribution of genetics to ADHD, but it's a strong one. And then the third factor that jumps out in the studies is having another trauma in the 6 months prior to an episode of depression starting. And the more recent trauma does not necessarily have to be on the magnitude of loved ones dying or serious physical illness. So certainly the COVID epidemic itself, loss of jobs connected with that, or loss of income, even if you have part of your job still present, the trauma that's being stirred up by the racial justice demonstrations going on, all of those could be trauma significant to trigger depression in people who are already predisposed to that. So a little bit about depression. Depression isn't just feeling sad. It can also constitute feeling numb or irritable, but it has to be a pervasive state that's lasting several weeks at a time. Almost always other negative feelings are accompanying it. So excessive guilt, some people have suggested maybe even more diagnostic for depression than just feelings of sadness, because grieving can cause sadness. other situations cause sadness. Social isolation or wanting to withdraw yourself from other interactions is characteristic. Um, Inability to feel joy, which is a little different than just feeling sadness. And the official word for not being able to feel joy is anhedonia. And depression is usually accompanied by physical changes, so decreases in energy level, disruptions in sleep, which can be either sleeping less, insomnia, or hypersomnia, sleeping much more than usual, often eating disturbances. Those can also go two different directions, decreased appetite and weight loss, or overeating and weight gain, and decreases in libido are commonly found in depression. So even though I've said depression and ADD commonly run together, I think there are also many people who are diagnosed with having depression by practitioners who are more familiar with depression than they are with ADD, who mistake the emotional dysregulation of ADD for depression. So we know with ADD, about 2/3 of people with ADD have objective measures of emotional dysregulation, and of people with ADHD who have the hyperactive type, it's a even higher correlation. And that emotional dysregulation tends to create emotions that come up much larger, much more explosively. And unless there's something distracting the person, they can become locked or fixated on those negative feelings. And that can happen for days at a time, usually not weeks at a time, again, if it's just rejection, if it's just emotional dysregulation connected with ADHD. But in the midst of it, that person can feel horribly negative. Part of what's helpful for getting someone out of it, if it's emotional dysregulation of ADHD, is to remind them that they have ADHD, to remind them, just as with the cognitive attentional focus, where they can be staring at the tree in front of them and need to step back and realize they're in a forest. That same phenomenon can be going on at an emotional area. So if they're looking at something that's happened, that's tragic, that's sad, that's horrible, that they're feeling really down and low, reminding them there may be other things in their life and that their ADD itself may be causing them to focus on this feature of what's their environment, while they're regarding the wealth of other things that may be good and positive. If it's, again, the emotional dysregulation of ADHD, that intervention itself can often help them get out of that negative state. Whereas if it's depression, it's less likely to be powerfully effective. I'm going to talk a little bit. One of my colleagues, William Dodson, has written extensively about what he calls rejection-sensitive dysphoria. This has been written up a lot in Attitude magazine and other places. And his formulation of it is that kids with ADHD get all sorts of negative feedback growing up, that they're doing this wrong, that they're bumping other kids, they're causing accidents, they're causing problems, they're noisy when they should be quiet, they're active when they should be sitting still. And he claims that this wires them or predisposes them to be hypersensitive to criticism when they get older, and that criticism taps into a whole host of deep-seated negative feelings, which can come out in explosive anger, can come out in extreme sadness. And that all sounds well and good and is reasonable. However, there's two things that come out in some of his writings where he says that one is that virtually everyone he's ever treated with ADHD has rejection-sensitive dysphoria, and that is categorically not at all my experience. So I see some people who have that, and I see many people with ADHD who have actually particularly bubbly, ebullient, positive, highly resilient attitudes, sort of like everything falls off them like water off a duck's back. So I don't think that all people with ADHD are suffering from rejection sensitivity. And secondly, he makes this as something unique to ADHD, and I would feel strongly that one is almost anyone on what's increasingly called the neurotypical spectrum, the autistic kid, the gay kid, the left-handed kid, all are growing up with a sense of feeling different, and depending on the society they're growing up on, but it's still by and large in American society, they are picked on, they are told they're wrong, they're told they're told they're different in a bad way or weird or strange. And I think the same constellation of processes that he describes for creating rejection sensitive dysphoria and ADHD exists for a host of other people who are neurotypical. So what can you do about depression? Getting back more fully to depression, again, which can coexist with ADHD. And I usually start before jumping into medications, even though I'm a psychiatrist who often prescribes medications. I've seen medications be life-saving in suicidal depressions. I've seen them be powerfully helpful before. But before jumping to medications, I always start with what I've called the big four when I was talking about scheduling. And that's sleep, eating, exercise, and meditation. So we know disrupting sleep is one of the best ways. I mean, this is, again, is a feedback loop. So depression measurably disrupts sleep, but disrupting sleep measurably puts you more at risk for developing depression, and studied both in bipolar depression and in unipolar, where someone only ever gets depressed in their life. Regulating sleep, making sure you're getting close to 8 hours of sleep, and not just 8 hours, the same 8 hours every night, can be powerfully helpful in getting someone out of depression or helping their body recover from it. And sometimes, even though I'm not a big fan of sleep agents, sometimes a sleep medication before starting an antidepressant, or sometimes in conjunction, measurably helps get someone out of depression faster. In terms of eating, I'm not going to say too much. There's a whole industry on eating certain foods, and that's going to cure your depression. I think there's a few supplements like fish oil, which have, at least in a number of studies, seem to be beneficial for treating depression and anxiety. And I've seen a handful of patients where those seem to be powerfully helpful, and a much larger number of patients where those seem to be moderately or mildly helpful. But I think if it were as simple as you eat fava beans every Tuesday or avoid grapefruit, I do not think that too many simple dietary changes are going to have a huge impact. Otherwise, we would be seeing huge cultural differences in rates of depression depending on dietary factors, which we don't see, actually, as a gross overstated rule. And part of that is that one is what we eat doesn't automatically go into our brain. There's what's called the blood-brain barrier. And two, that some of the things we've seen in the laboratory system. So if you feed someone a specific diet, rich in certain amino acids, deficient in others, you can actually cause a serotonin deficit in the person's brain, and that can evoke depressive feelings in certain people. But someone eating either plant-sourced proteins or animal-sourced proteins is not going to get such a skewed sampling of amino acids. Again, you can do it in a laboratory situation, but eating general plant sources or general animal sources of protein, those protein sources break down into a pretty broad spectrum of amino acids that you need to build up your own proteins. So the other two pieces of the big four are exercise. There are several dozen studies now looking particularly at running, and that seems to be an effective intervention for people who were sedentary before they became active, before they became depressed, in terms of treating depression. I don't think that there's anything special about running, although there might. It's just that it's easy to standardize across testing centers and across individuals to make sure, are you running 20 minutes a week, rather than finding access to a gym and measuring different aerobic exercises or weight-bearing exercises may be harder to standardize. And there's growing evidence that meditation-based practices can have both preventive effects in terms of lowering your propensity to getting depressed, and may be helpful in getting brains out of depression. Jumping one last thing into eating and food, next week's session is going to be on alcohol and primarily on why alcohol is such a bad idea for anyone with depression. So beyond the basic four, we have a number of medications. What I'm going to say there is, again, talking to the ADD component, is it's the stimulants, which are the mainstay for medication treatment for ADHD. Most of them, including particularly Adderall and Ritalin, have extensive histories of being looked at for treating depression. And they work, and they're fast, and they're effective. And it sort of puts a damper on the whole hullabaloo around ketamine of the last decade, that repeated claims, even in the psychiatric literature, about 90% of things I've seen said, ketamine, the first thing we have that immediately gets rid of depression. Completely wrong. We have studies going back 60 years. Adderall gets rid of depression within a day or two. Now, one critical difference is with ketamine, usually a single dose, the effects as an antidepressant last a few days to a few weeks, whereas with the stimulants, when they work for depression, you tend to keep needing them. So it's having the drug in your body. Blood levels of it do seem to correlate with the antidepressant effect. There are a host of other biological interventions, transcranial magnetic stimulation, electroconvulsive therapy, deep brain stimulation, vagal nerve stimulation, cranial electrical stimulation, which are little devices with very low voltage currents, all of which have moderate to very good evidence they're helpful for depression. I won't talk about them more right now. I'm going to jump and spend the last few minutes on cognitive behavioral therapy. So cognitive behavioral therapy, which is teaching you how to essentially reprogram your brain, and it's based on the idea that your brain is in charge of all your emotions, in charge of all your behaviors, and in charge of all your thoughts. And usually, and all three of those can interact and affect the others. Usually we think of, how you're feeling is going to change how you behave. You're going to stay in bed rather than going to work, and how you feel may change your thoughts. So you may become more focused on the negative about your spouse or partner. But it's not just a unilateral feelings affecting behaviors and thoughts. Each of them affect the others. So how you think measurably can have an impact on how you wind up feeling. How you think can change how you behave, and how you behave can change how you act and how you feel. And cognitive behavioral therapy focuses on cognitions or thoughts and behaviors, because most of us have much more conscious ability to change those and thereby change feelings. And I'm going to talk a little bit about a subset of cognitive behavioral therapy called behavioral activation for depression. And it encourages people to get up, or schedules them and uses CBT, cognitive behavioral tricks and tools, to get them out and engaged in doing pleasurable activities. And measurably, our CBT approaches as a group have clear and robust antidepressant effects that are as robust as the antidepressant effects of our medication. They do tend to work substantially more slowly than the medications do, so on several weeks to a few months. On the other hand, they have a much better track record for looking how well people do after they stop treatment. So after stopping medications, the longer out you go, the higher rate of recurrence to depression occurs. With CBT, that recurrence of depression seems to be much lower than it does for people who have stopped medication treatment. So part of why behavioral activation may be particularly effective, and this is a finding in the last few years, we've been shifting in brain research from focus on specific areas like the hippocampus or the prefrontal cortex or the anterior cingulate cortex, to looking more at networks and how different parts of the brain are connected to subserve different functions. And for the first few years of studying networks in MRI and other machines, functional MRI machines, they would instruct patients to do a certain task, to look at what circuitry was activated by doing that task. And then as a control, they would tell the person, well, just sort of think of nothing, don't think about anything. And instead of just sort of random nothing being activated, it turned out that telling someone to do nothing activates a certain system which is called the default network. And it's called the default network, maybe not the best name, because that was the default used as a control for these studies. The interesting thing that's coming up regarding depression is that people who tend to wind up in depression have an overly connected, overly strong, overly robust default network. So it's thought that the default network system is what happens when you're ruminating, but the people who practice ruminating a lot are practicing being depressed or anxious. So there's a lot of overlap between depression and anxiety. And once you're in a depressed state, or a highly anxious state, most people are aware that a lot of their time is spent in these negative ruminations, not productive problem solving, it's mulling over the same, and not in an OCD, purely thinking over the exact same specific thought over and over, but thinking over a wealth of negative thoughts over and over and over again, and being locked. People talk about being stuck inside their heads. So behavioral activation focuses on getting people out and interacting. So it's engaging a very different network in the brain. And the more we can activate these salience and behavioral and engagement networks and deactivate the default network, the more powerfully we get people out of depressive states. So I've said, I know this is a cram course in 21 minutes on depression. There's a wealth of other things I could say. I am happy to wait a minute and see if anyone has notes. I will make a plug for next week. Again, I'll be talking about alcohol, and particularly alcohol and depression. And I will make a plug for my book for a minute. So my book, Recognizing Adult ADHD, it's three books in one. So the first book is using Donald Trump as an example to teach people who are not familiar with ADHD or aren't recognizing it, how to recognize features and symptoms of ADHD, because ADHD is clearly much more than, oh, there's a squirrel. Second, the book uses ADHD to explain much of President Trump's aberrant behavior, because it's not just narcissism, it's not just sociopathy. And three, the book talks about how our whole society is getting more ADHD-like because of social media, because of sleep deprivation, because of stranger eating habits and decreased exercise habits, and because of President Trump himself, and that we should be paying more attention to this, because it's almost certainly going to be causing more people who would have been at a less severe point on the ADD spectrum to wind up on a more severe part of the ADD spectrum. So all of us are becoming a little more ADD-like, and that has big implications for society. So I'm not seeing any comments coming in. Again, if you have questions that come up later, you can certainly post them on that site. I think it takes a few minutes before this posted. So have a safe and sane week in an increasingly non-sane world. So there's a question coming in. It says, chemically, how strong of a correlation is there with depression and an over-under supply of specific levels in the brain? And I'm guessing it's saying specific brain levels of certain neurochemicals. Or I'll go on a tangent first. So one of the things I've seen lots of posts for and comments on and advertisements for is take vitamin D because it's going to help you with your depression. So two very conflicting pieces of information I'll say. One is there have been several studies treating the next 100 people come in the door with depression with vitamin D, and big studies like that have very consistently shown no impact on groups of people with vitamin D treatment and depression. On the other hand, if you selectively look at people who have both low vitamin D and depression and treat those small subset of people with vitamin D, very often vitamin D can have an antidepressant effect. So there may be certain things certain subsets, and it might be small subsets of people with depression have certain deficiencies or problems where supplementing by food or food-like substances may help. So with the brain, the depression is clearly simply not a simple serotonin deficit, and I would say the best evidence for that is actually the serotonin reuptake inhibitors. If a simple deficit in this neurochemical caused it, then the SSRIs and many of our other agents cause immediate boosts in availability of serotonin. That doesn't relieve depression in almost anybody. Maybe 1 to 3% of people are fast responders. Messing with serotonin levels takes weeks, days to weeks, to alleviate depression. And the thought is that changing the serotonin is serving as a signal to the brain, saying, brain, hey brain, make new proteins, stick those proteins in nerve cell membranes, change how nerve cells talk to each other, maybe even build and make new neurons. And all of those processes take days to weeks at a time, which is why almost all of our conventional antidepressants takes days and weeks to work. Those are systems that take a while to get geared up. But again, it pretty clearly refutes that the essence of depression is a simple depletion of serotonin, because that we should be remedying much more quickly. And actually most studies that have looked, do we see low serotonin levels are not finding robust differences between depressed and non-depressed people. So I hope that answered that. And if there's no other questions, then I will sign off till next Friday at 11. Again, have a good week and be safe.